Hello, and welcome to the Journal of Neuro-Oncology's webinar series brought to you by the AANS and CNS Joint Section on Tumors. My name is David Shin from the University of Florida Department of Neurosurgery, and this topic will focus on the surgical considerations for immunotherapy in the treatment of malignant glioma.
First, we'll discuss the goals of surgery. Of course, having a tissue diagnosis is the first step in any further surgical or oncological decision-making for the patient. While there are certain imaging characteristics and patient demographics that make the diagnosis of a high-grade glioma most likely, it is not uncommon to receive an unexpected frozen diagnosis that changes surgical management, such as CNS lymphoma. It also goes without saying that medical management of cerebral edema and mass effect has limited capabilities to fully address this problem. Thus, there will always be a role for surgery in the direct treatment of patient symptoms and to improve their neurologic deficits. However, it is undeniable that the primary purpose of surgery is to improve overall survival with gross total resection if possible. There is ample literature indicating that aggressive extent of resection, even greater than 95%, confers a significant survival benefit for newly diagnosed GBM. Additionally, even in recurrent GBM, extent of resection more than 80% also results in a significant survival benefit. However, this comes with a caveat. We now know that achieving a good resection while also creating a new postoperative deficit abrogates any survival benefit the patient would have experienced otherwise. Finally, the new up-and-coming use for surgery comes in the realm of further research purposes, specifically as it relates to immunotherapy and genomic analysis. When it comes to the development of personalized precision medicine, it is vital to obtain a sufficient amount of tissue for use in the generation of these products. Specifically, the tissue that is collected can be used to generate nucleic acids, lysates, or specific antigens needed for targeting purposes. For example, at the University of Florida, we currently have several ongoing clinical trials evaluating the use of ex vivo T-cell expansion. This expansion is based on the extraction of total tumor RNA from the resected tissue, which is then pulsed into dendritic cells that are isolated from the patient's peripheral blood mononuclear cells and subsequently given as a vaccination. The degree of success of these types of treatment strategies is somewhat dependent on the total volume of tissue provided to the translational laboratory, which generates the nucleic acids. Thus, it is critical for the neurosurgeon to keep this in mind as they perform these resections. Finally, continuing along the lines of precision medicine, there are additional research purposes that allow for the potential determination of prognosis as well as finding actionable mutations. Here at the University of Florida, we have a large interest in high-throughput analysis based on bulk RNA sequencing of the tumor sample. Here's an example of the workflow in the generation of these antigens of interest using an open reading frame analysis. Essentially, this methodology has allowed us to identify a large number of unique tumor-specific and potentially actionable mutations. We'll now move on to briefly discuss the tools within the neurosurgeon's armamentarium that are designed to assist with the successful resection of these tumors. Neuronavigation, once initially scorned by the neurosurgical community in the past, has now become a standard in neurosurgical oncology. Using high-resolution multi-slice preoperative contrasted MRI or CT scans, these images can now be easily applied to a live intraoperative setting to help guide multiple aspects of the operation. As we all know, this market is mostly dominated by Medtronic Stealth and BrainLab, which both have their merits in facilitating a surgical procedure. Along with these types of imaging studies, data from fMRI and tractography can also be applied in order to allow for safe trajectory planning with minimal disruption of critical structures and pathways to limit the risk of postoperative deficit. Other tools that are related to actual intraoperative image acquisition include the use of ultrasound and MRI, which primarily serve to determine residual tumor volume. Fluorescent-guided surgery has also been of great interest in the field of neurosurgical oncology, as a live determination of tumor cells intraoperatively is also critical for surgical success. Whereas neuronavigation allows for the safe guidance to the region of the tumor, There are logistics that limit the true accuracy of this technique, such as CSF loss leading to brain shift or poor registration. On the other hand, fluorescent-guided surgery shows the neurosurgeon real-time information about the tissue undergoing resection. The two main types of this technology include fluorescein and 5-ALA. Fluorescein has been in use in surgical oncology for many decades in the United States and has been shown to facilitate aggressive gross total resection for glioma. However, a significant limitation is that it is primarily based on disruption of the blood-brain barrier, which can be nonspecific to a certain degree. On the other hand, 5-ALA is a compound that was recently approved by the FDA and is selectively metabolized by tumor cells into a compound known as protoporphyrin IX. This can then be detected under fluorescence. This compound had been widely used in Europe prior to its recent introduction and approval in the United States, and has also been shown to be effective in achieving gross total resection. When it comes to preventing neurologic deficit, using tractography, fMRI, and adequate preoperative planning are essential. However, none can replace the ability to actually assess the patient's neurologic status while they are undergoing their procedure. The awake craniotomy is a major tool that allows for the neurosurgeon to safely resect and evaluate the patient in real time. However, this can be a challenging enterprise as it requires a skilled multidisciplinary team that is familiar with working towards this goal. In doing this type of procedure, one could perform intraoperative cortical mapping to absolutely ensure that the corridor into the tumor will not result in harm. Additionally, it is critical to appropriately identify patients that are well suited for this kind of procedure with robust neurophysiological and neuropsychological testing to prevent untoward patient-specific intraoperative events. Finally, for deep-seated inaccessible lesions, or perhaps for patients who have multiple complex medical comorbidities, another option to seriously consider is the use of laser interstitial thermal therapy, or LIT. Currently, there are two commercial systems in use, the Monteris NeuroBlate and the Medtronic Visualase. With the advent of MR thermography to monitor temperature levels in the lesion and perilegional regions, the use of LIT for the treatment of previously untreatable lesions has grown significantly across the country. Additionally, there are important implications for the hyperthermic disruption of the blood-brain barrier and its potential interaction with immunotherapy that will be discussed later. Moving on to the actual delivery of immunotherapy, there is always the generally patient-preferred option of extracranial delivery of the agents of choice, whether or not it is a monoclonal antibody infusion, subcutaneous vaccination, or lymphocyte transfer. The unique aspect of direct access by the neurosurgeon, on the other hand, provides an opportunity to bypass the majority of the pharmacokinetics that potentially limit the successes of other extracranial treatment modalities. For example, there have been long-term survivors reported with the direct administration of a recombinant polio rhinovirus vaccine into the resection cavity by a group out of Duke University. This virus recognizes CD155, a poliovirus receptor which is widely expressed on neoplastic cells. Additionally, a chimeric antigen receptor T-cell platform against interleukin-13 receptor alpha-2 from the Beckman Research Institute demonstrated significant regression of glioblastoma with the placement of an intracavitary and intrathecal catheter with multiple infusions of this therapy. It remains to be seen if these successes can be translated into larger scale. Nonetheless, the advantages of these methods are clear in that the blood-brain barrier is completely bypassed with the possibility of reducing systemic effects. On the other hand, with any procedure, there is a risk of peri-procedural complications, regardless of how benign the actual operation may be. Next, we'll discuss the relevance of the timing of immunotherapy. Traditionally, it is administered in the post-operative period, where unfortunately the majority of the large-scale trials seeking to address the efficacy of immunotherapy, where it has found successes in other cancers such as lung and skin with anti-PD-1 therapy, have failed to demonstrate a clinically meaningful benefit. One such possibility for the limited effectiveness of these strategies is the actual timing of therapy, referred to as the window of opportunity. In a major study by Closey et al., they demonstrated the use of preoperative neoadjuvant anti-PD-1 therapy and resulted in an improved response to treatment as well as a survival advantage in these patients. Additionally, further analysis by a separate group demonstrated that the use of neoadjuvant therapy significantly modulates the tumor microenvironment to increase immune cell infiltration as well as T cell receptor clonal diversity. Although, as with all smaller scale investigations, it is unclear if this benefit will persist on a large scale. Obvious disadvantages of this therapy is the increased cost of the hospitalization, as the patient will need days prior to the operation in order to receive their immunotherapy. This also runs the risk of a patient experiencing worsening and potentially irreversible neurologic deficits, depending on the total mass effect of their lesion if definitive surgical treatment is delayed.
Finally, there is good evidence that immunotherapy can be augmented by the use of techniques that currently exist other than direct intracranial administration by improving delivery of the therapy to the actual tumor site. The theory behind this primarily relies on the selective disruption of the blood-brain barrier, which can then be leveraged for other types of therapies such as previously non-CNS penetrating chemotherapeutic agents. One such method to achieve this is through MRI-guided focused ultrasound, which utilizes microbubbles carrying the agent of interest across the blood-brain barrier upon target disruption. The other method, as alluded to before, is through LIT, which evidence has shown can lead to prolonged blood-brain barrier disruption weeks after the treatment. Clinical evidence of the synergistic effect of this treatment modality is currently being investigated at our institution, where there has been improved overall survival in patients with this combination therapy in newly diagnosed GBM in a phase 2 study. This hyperthermic permeability of the blood-brain barrier after LIT was studied extensively by Luthard et al. In their study, they evaluated a mathematical model in contrasted MRI investigating gadolinium pharmacokinetics in the peritumoral region of postoperative patients with serial imaging, and they demonstrated a measurable transient gadolinium permeability decreasing over time. Additionally, they demonstrated the persistence of CNS-specific biomarkers, such as brain-specific enolase, in the serum of these patients. The authors concluded in this study that this effect lasts up to 4 weeks after therapy. As a result, it is hypothesized that the survival benefit seen in our own LIT plus immunotherapy trial, mentioned previously, is a result of this transient permeability. Subsequently, our institution has very recently started a clinical trial investigating intracranial metastases treated with a combination of LIT and anti-PD-1 therapy.
Some additional considerations regarding the role of surgery in the setting of immunotherapy is the fact that it is currently near inevitable that there is recurrence of tumors. As a result, there should be great interest in the evaluation of the post-treatment tissue to assess the effect of the immunotherapeutic treatment on the tumor microenvironment. To conclude, surgery allows for diagnosis, relief of neurologic deficits, and opens up opportunities for immunotherapeutic options. There are a wide variety of tools available to the neurosurgeon to accomplish a safe and maximal tumor resection. The timing of therapy, specifically neoadjuvant therapy, has potentially important implications for future treatment paradigms. Finally, the administration of immunotherapy has the potential to be augmented by both invasive and non-invasive methods. Further studies are needed to validate the promising survival benefits seen in the studies discussed in this webinar, and there should be cause for hope that a durable treatment option for glioblastoma is on its way. Thank you for your attention.